Next speaker, it's a pleasure to welcome Josh Richter from Hackensack. He'll be speaking about newly diagnosed, basically the Myeloma 101 disease overview, prognosis, and risk. And it's a pleasure to have him here. Thank you.
Thank you so much. Good morning, and thank you so much for, wow, there's so many of you. Thank you for coming out today, and thank you to the MMRF and Dr. Chari for having me here, and to the patients and caregivers. So I've been tasked with the Myeloma 101, and I really like this talk. It's actually my favorite because I think one of the most complicated things about this disease, we spend all this time in the encounters talking about what our next treatment strategy is, what do we need to do to manage side effects. But I don't know that there's always so much time to talk about what myeloma is and really kind of the nuts and bolts of the disease so that we all understand it to work better to reach a cure. So my first question is, my or my loved one's multiple myeloma disease activity is primarily measured by the M protein, the serum free light chains, a 24-hour urine test, bone marrow biopsy, or I don't know. Rick Springfield? All right, so it seems that most people are really measured by the M spike or the M protein, and we're going to go into a little bit about what that actually is more than just this number on a piece of paper that determines whether or not we're responding to therapy or not. So what is multiple myeloma? And, you know, I think people have already brought up today that myeloma is this big heterogeneous disease, and we know so much about cancer at a genetic level. But still, in 2017, we define individual cancers by what cell becomes malignant. So in lung cancer, it's a lung cell that becomes malignant. Melanoma is a malignancy of skin cells. Multiple myeloma at its core is a malignancy of plasma cells. And plasma cells are immune cells that live in the bone marrow, and under normal circumstances, they secrete antibodies and proteins to fight off infections. But in myeloma, they don't really secrete necessarily functioning antibodies, but they secrete bad proteins, and this is that M spike that we all talk about. So this is kind of a diagram of how the development of the cells goes inside our bone marrow. And under regular circumstances, the stem cell gives rise to different types of lymphocytes, and there's T cells and B cells. And B cells differentiate even further to plasma cells. And normal functioning plasma cells secrete antibodies to fight infection. When multiple myeloma or its related disorders develop, that process has a problem at some level, and you develop a malignant plasma cell that releases abnormal proteins. So multiple myeloma actually is the second most common blood cancer. In actually some respects, it's actually the most common because non-Hodgkin's lymphoma is often referred to as the most common, but there are many different types of non-Hodgkin's lymphoma that we've identified. Diffuse large B cell, follicular, mantle cell. As an entity, myeloma probably represents the most common, and there are literally over 100,000 people now living with myeloma in this country. That number has risen very steeply over the last decade because people are living longer and longer and longer. You look at textbooks from maybe only a decade ago, and it was about 40 to 60,000. Now this number is higher. If you go on the SEER webpage, it's actually almost 120,000. It still represents about 1.8% of all cancers, and the average age is around 69 to 70. But as Dr. Chari pointed out, there are people really, really young and really, really old. It kind of spans the whole gamut. So there really isn't an archetypical patient. It can affect almost anyone. So what are the common symptoms of myeloma? And I have to admit, any time in this presentation that there's an animation, I actually stole this from Dr. Cole. So if you ever see him, please don't tell him that I took his slides. So low blood counts are one of the big things of myeloma. Because plasma cells live in the bone marrow, if they expand and grow like a cancer does, they start to crowd out the normal functioning cells. So you don't have as much normal marrow to make blood cells, and your blood counts can drop. As your blood counts drop, like your red cells, you become more anemic. And anemia can cause fatigue, shortness of breath, and infection, because if you don't have that normal complement of cells making healthy antibodies, then you don't have it that, it's like part of your army is on vacation, so you're more prone to certain infections. That bad protein, that M spike, can circulate in the blood, and the kidneys are like a filter for the blood. So it's like not getting your oil changed for 100,000 miles. The protein can start clogging up the kidneys, and you can have kidney problems as a result. Bone problems. Unfortunately, I'm sure there are people in this room that have had bone problems from myeloma. There's different cells that kind of regulate our bones. They build up bone and break down bone, but osteoclasts, these big cells that kind of crunch up bone and put holes in there, they can be upregulated in myeloma, meaning that you get holes in the bones, and if you get them in certain areas, especially weight-bearing areas, you can get fractures. Bone turnover, high calcium levels. High calcium levels can cause a lot of issues in terms of your kidneys and your overall well-being. But the really difficult thing for many people to appreciate is that 10 to 20% of myeloma patients have no symptoms. I'm sure there's someone in this audience who went to their primary care doctor, got routine blood work, felt completely fine. The routine blood work led to a consult with an oncologist, and now you're sitting across from a physician who's telling you have myeloma when you feel completely fine. And that's the really complicated thing. So we're trying to seek ways not just of treating the disease, but identifying it early and preventing progression. So there are key things to look at when we're evaluating myeloma. Looking at all the tests, lab tests, imaging tests, staging and prognosis has importance. And obtaining a second opinion, I can't stress this enough, that there are speakers here from many different institutions who see lots of patients with myeloma. If you're seen by a physician or a care team at your local place of living, they may or may not see a lot of disease like this. And it may be worthwhile, even if it's just once or every now and again, to seek out someone like Dr. Chari, Dr. Gobrel, Dr. Cho, because they have this expertise, and we oftentimes work together with local teams to make sure that even if you're far away from one of these places, we can work together to achieve the best outcomes. Know what the standard of care, and clinical trials, I think, have sometimes a bad connotation. People think, oh, I'm just going to get placebo. Many trials nowadays don't have placebos because we have standards of care. And clinical trials are not just for people with no options. We use these earlier on, and the reality is if you become part of a clinical trial early on in your disease, you still have every other standard option after that. So when it inserts another option and really is, part of the way that we move forward in treating the disease. So when you go follow your tests at your individual institutions, you'll get a whole smattering of lab tests. The most common one is a CBC, a complete blood count. Lets us look at three big areas: your white cells, your red cells, and your platelets. White cells help you fight infection, so if they're too low, you may be at more risk. Also lets us know if it's safe to give you treatment that day. The red blood count lets us know if you're too anemic, do we need to give you a blood transfusion, or sometimes medicines like Procrit to raise your red count. And platelets prevent us from bleeding, so if the platelets get too low, we may need to hold that aspirin or the Coumadin, and we may need to monitor. Complete metabolic panel looks at your chemistries, your kidney function, your electrolytes. We want to make sure that kidney health is really maintained throughout the different therapies. Beta-2 microglobulin, you may see it's part of the original staging. It also may have some prognostic value. The SPEP and the IFE, those are the two big ones. So the SPEP and the IFE tell us about that M spike. And the M spike is kind of like the Heisenberg uncertainty principle of physics. If anyone's familiar, you can't know the velocity and location at the same time. The SPEC tells you how big the spike is, but it doesn't tell you what it is. The IFE tells you what it is, and there's different types, IgG, IgA, so you need both together to find out how much of the bad protein and what type it is. And it's not necessarily that one type is better or worse, but it lets us know how to follow your individual disease. The serum-free light chains, another way, sometimes they're little parts of the bad protein called the light chain, and we'll go through that help us measure if your disease is getting better or worse. And those horrible orange jugs for the 24-hour urines that everybody hates, that are sitting with someone at home that you're dreading, they still do play a role in modern-day management because there's a lot of information we can glean from that. So what is an M spike? So on your stage left, yes, sorry, I'm a little dyslexic. So on the left is a normal, what's called SPEP, a serum protein electrophoresis. And this looks at all the proteins in your body. And every tick along the way is another protein. The higher it is, the more of it. And if it comes to a peak, that means it's just one. These big humps mean there's plenty. So there's like a little protein here, a little one here, a little one here, a little one here, and it sums over this. This big one over here is albumin. It's like the white of an egg. It's in everything. It's ubiquitous, and there's a lot of it in your body, and it's just one protein. So it's a high peak, and it comes to a little peak at the top. These are where your gamma globulins live, and this is where the proteins that plasma cells make live. And normally you have some plasma cells making a protein to fight the flu and the cold and shingles and so on and so forth, and there's a lot of little ones. But when you have a bad plasma cell group in a disorder like myeloma, you have one large group of plasma cells making a lot of the same bad protein. Because they're all the same cells, they're all related to one another, they all make an identical bad protein. This is a schematic. This is not the flux capacitor from Back to the Future, I swear. This has nothing to do with time travel, but this is what those proteins look like. And there's two big parts, and we're scientists. This is very technical. The big part is heavy, so we call it the heavy chain. The top part is light, so we call it the light chain, and that's it. And in everyone, there's all different types of plasma cells. So in everyone, everywhere, you have all the different types. Now, the heavy chain comes in different varieties, IgA, G, M. Ig stands for Immunoglobulin, proteins from immune cells. The light chains come in kappa and lambda. So in everybody, you have IgG kappa cells, and IgG lambda, and IgA kappa, and IgA lambda, and so on. Whatever group becomes abnormal, it makes too much of that bad protein, and that's the type of myeloma that you have. IgG kappa being the most common. Now, the question earlier is, how is your disease measured? Well, most people, as it was, we see, is measured by that M spike, the whole bad protein, the heavy chain and the light chain together. But it's not everybody. Some people, the cells only spit out that light chain, so you're only kappa or lambda, in which case this is all we see. Some people can even be oligosecretory, where normally there's a correlation. A lot of bad disease in the marrow is a lot of bad protein in the blood, less and less. Sometimes they don't coordinate. So you can have a marrow filled with bad disease, but only a small amount of protein. We call that oligosecretory. And even some people, the cells are so abnormal, they don't even make the protein. So people can have growths called plasmacytomas that don't make the protein, and we have to monitor them a bit differently. So the dreaded bone marrow test. We all hate this test on both sides. And the hope is that one day with the technology that we have, we can get around having to do this. But for the moment, we really need it because it gives us a lot of information. One, it tells us how much myeloma is inside your bone marrow. But more important than that, it gives us the genetic information to identify what's special about your myeloma and what can we exploit to kill the cells in a better way. So this is always where I get to feel like Patton, like this is your enemy, this is what we're fighting against. These are the myeloma cells, and myeloma cells have this classic look. They're big, blue, ugly cells with a big open nucleus and this clearing that we call a perinuclear Hoff. And this is, if you remember back to high school biology, the Golgi apparatus and the ribosomes, this is where that is. So yes, high school biology is coming back to haunt you yet again. So why is this important? Well, we have to do this test to find out individual factors about your myeloma because every person's myeloma is different and can be treated different ways. And the goal is to use this to provide precise medicine, not global treatments, but individual treatments. And the COMPASS trial is really that, the pinnacle of that, of taking all the information that we may not think is important now, but when we look at the data set, may prove to be that, Caucasian females with IgA myeloma and a 414 translocation don't benefit from transplant. And it may be that type of setting where it's not just a genetic marker, but some demographic marker or some cultural or ethnic changes. We really need to be sure that we take into account all this data to provide the best therapy. And we get all these different tests, and it's not just blood tests and bone marrows, but we put our patients through x-rays and CAT scans and PET scans, and we look for the telltale signs of myeloma. And the biggest thing on these scans are little holes in the bones we call lytic lesions, and we can see them with more and more fidelity on things like PET scans and CAT scans. So we put it all together, imaging results, blood tests, bone marrow, and we try to figure out what the best treatment is. But first, another question. Which of the following is not an imaging modality in myeloma? X-ray, MRI, PET scan, CAT scan, dog scan. Little known fact, the lead singer of Flock of Seagulls who sings this song was actually a hairdresser before he was in the band. He did the hair for most of the band. It was the 80s. It's true. He was. Great video with the mirrors. All right. Yes, a dog scan, although I'm working on it, has yet to become a standard of care in myeloma. All right, so knowing the diagnosis. So we've done the bone marrow, we've done the imaging, we've done the blood test, and we found some bad protein. We know it's correlated to some bad cells. So what does that mean? It doesn't mean that everyone has myeloma that has this. In fact, the majority of people that have a bad bunch of cells making some bad protein, it's not myeloma. It's a precursor we call MGUS. MGUS stands for monoclonal gammopathy of undetermined significance. And monoclonal gammopathy means that one bad protein. And undetermined significance we used to not know. We now know, but we're stubborn doctors. We're not changing the name. And what it really means is that on the whole, people who have MGUS have about a 1% chance per year of developing myeloma. And it's where you have some of the bad cells, but less than 10% in your marrow. You make some of that bad M spike, but less than 3 grams, and you have no symptoms. Smoldering myeloma is where you have more of that bad protein, more than 10%, but less than 60. and you have more than 3 grams of that bad protein in the blood, we call that smoldering myeloma, or myeloma that doesn't require therapy, also sometimes called asymptomatic. And on the whole, people with smoldering have about a 10% chance per year of progressing. But if you have more than 10% and you have one of the what we call defining characteristics, which we call slim crab, so more than 60% of plasma cells in your bone marrow we usually treat. Those light chains, that kappa and lambda, if the ratio is more than 100 to 1, we normally treat. If you have lesions on an MRI or on an X-ray, we know that your disease is becoming active. And things like anemia, kidney problems, high calcium levels, if you're having these and they're related to the bad proteins in the bad cells, we know that your protein problem is actually going to cause trouble. We need to treat it. So how do we stage myeloma? And this is something that's hard, I think, for the family and friends of the patient and the caregiver to understand, that the staging is very different than every other cancer. Every other cancer uses this thing called the AJCC, and it goes from 1 to 4. There is no stage 4 in myeloma. And actually, stage at the moment doesn't affect the way we treat. In lung cancer and breast cancer, stage very much dictates. Do we do surgery, radiation, chemotherapy? In myeloma, the stage doesn't affect that. It just gives us some idea either of burden, how much disease is there, or prognosis. So the Dury-Salmon system, which is the original staging system that goes from 1 to 3 and has an A or B designation, A is your kidneys are fine, B is your kidneys are not, didn't really give us prognostic information. It meant if we sucked out every myeloma cell and put it in a glass, stage 1, stage 2, stage 3. And then again, you can have a lot of disease that's very sensitive, or you can have a little disease that's not. So the amount of disease doesn't necessarily correlate to how you do. But then we revised this with the international staging system and the revised international staging system. And the revised one not only takes into account some of the factors in terms of your blood levels, but it looks at those genetic informations that we really want to pinpoint as people having better risk or worse risk overall. And there's a website we can all go to called MSmart. msmart.org. It's a website that's run by the Mayo Clinic, and they update it regularly, and they look at these genetic abnormalities. That we look at the chromosomes inside the cancer cells, what chromosomes predict for people doing better or worse, and how should this direct therapy. So part of this is a global understanding, is someone's disease is genetically higher risk or lower risk, but what we're really looking for is to pinpoint eventually each one of these abnormalities and design specific therapy programs for each individual patient. So ultimately, we should always be asking our care team, what type of myeloma do I have? IgA kappa, free lambda, and this is important because then it empowers you and you can look at your lab results and say, I have IgA myeloma and my IgA is down. I know I'm doing better. And these things are really important just for global health and outcome. And what is my stage? And again, the stage doesn't necessarily predict for what type of treatment, but at some point it might. Do I have any cytogenetic abnormalities, and are there specific trials out there, or are there specific data sets to guide how people with this type of myeloma ought to be treated? Again, is why I can't stress enough how important it is to, at least at one point in your journey, visit a place like Mount Sinai or Dana-Farber to have that, or even Hackensack, to have that knowledge of, how can my local physician, local physicians, they've done studies. Hem-onc docs see between 0 and 10 cases of myeloma per year. At centers like the ones for the speakers today, we see hundreds every day. It's just a different thing. It's a different expertise. And then what treatment option should I consider? Is transplant right for me? Is it not? 3 drugs may be better than 2 for many people, but for some people who may be frailer or may not be appropriate, 2 may be right for you. So there is no one-size-fits-all. So other speakers are going to go through the general treatment overview in terms of specifics, but I'm going to give you the 10,000-foot view. So if you have MGUS, if that's where we kind of place your diagnosis, we monitor at different intervals. But for the most part, people get monitored anywhere between every 3 months and every 12 months. Some of the Mayo Clinic data says for really, really low risk, you can probably go to every 3 years, but I'd miss you too much. For smoldering myeloma, again, the current standard is just to monitor. But there are many clinical trials going on, including some done by Dr. Gabriel, that are looking to say, if we know certain people are definitely going to progress or have a higher risk of progressing, why should we wait until something bad happens? Let's act on it now. So as we begin to understand, we really start to separate out. If you're never going to need treatment, let's not treat you. If you're going to need treatment, let's try to do something now where if we knock it down before it starts causing trouble, we may be able to really affect things at a huge level. When it comes to symptomatic myeloma, we know that we need to treat, and there are many, many ways of treating. This is kind of an overview of, inception of myeloma from the first documented case of Sarah Newberry in 1844, where her primary treatment, as it was back then, was bloodletting. And for those of you who have been anemic and felt like that, imagine going to your physician and says, okay, I'm going to take off a couple of liters. She didn't really like that too much. And starting with drugs like steel and quinine, those were the standards of care back then. And again, my hope is that we'll look back years from now at the current therapies we use and say, I can't believe that was the state of the art then. Imagine what we'll have years from now. But we've really come an amazing way. And in the last decade, that's where all the amazing stuff has happened. Proteasome inhibitors, immunomodulatory agents, monoclonal antibodies. We're really starting to define way better outcomes and way better precision medicine so that we can really dial it down, not for every myeloma patient, but for you as an individual, what's the best for you, and we have data to support this. And again, this is where we're at right now. These dizzying slides of a huge repertoire of drugs that are available in the clinic, drugs that are almost going to be available in the clinic, and drugs that are 5 and 10 years off. And again, that's our global thought together to work together to find the therapies for today and tomorrow. So myeloma can have numerous effects on the body. And at the end of the day, you know your body better than anyone else. Don't be shy. When you come to see any of us in the clinic, tell us what's going on. What may not be important to you may be important to us. It may be a sign of something good or bad that we ought to know. Neuropathy, fatigue, we want to know about these things. Please don't be shy. The more we work together on both sides, the better we're going to be at defining therapy for you to optimize outcome, but quality of life as well. We're going to use the genomic information from many, many patients to really create a blueprint for everyone all over the world so that everyone, no matter where you are, if you see one case a year, you'll be able to access this information. And it doesn't matter if you see one case a year. You'll be able to provide almost the same level of care as Dr. Chari, not quite that level, but almost at Dr. Chari's level. And again, we're improving survival, and the paradigm is really in a process of changing, and we're almost there. And I end every slide because this is just kind of my favorite thing about all this is not the end. It's not even the beginning of the end, but it is perhaps the end of the beginning. And thank you guys so much for coming out.
So great talk. We have, I'll lump it into two groups of questions. One is relating to diagnosis, which is why is myeloma called multiple myeloma? What causes kidney dysfunction, meds or disease? And you go back and forth in stages. So all pertaining to diagnosis.
All right. So multiple myeloma, the general reason is that when you have these plasma cell problems, there's actually more diseases than just the three I mentioned. And one of them is the concept of a solitary plasmacytoma. And for people with that, pretty much all, if not almost all of their disease is located in one spot. And that one spot can just be radiated, and that's the treatment. But in multiple myeloma, it's often in multiple spots all over the body or within the bone marrow, and that's generally why we call it multiple myeloma. In terms of kidney dysfunction, there's literally a laundry list of things that can affect the kidneys. If your calcium level goes too high, that can affect the kidneys. If the protein clogs up the kidneys, that can affect it. But also certain medicines can. So NSAIDs, drugs like ibuprofen and Aleve, they can affect the kidneys. Dehydration can affect the kidneys. So it's the drugs themselves that we use usually do not, but certain medicines that we use in conjunction for supportive care can. So it's really important to let your care team know about any medicines, prescription or over-the-counter or herbal, so that we have a full grasp on everything. And stage, I actually have this debate quite a bit. At my institution, I don't feel that you ever change stage, but I don't know if that's the general consensus. My feeling is that once you're at the stage, that's where you're at.
So there's a recent Mayo paper that's just looked at this, which showed that even with relapse disease, the international stage is prognostic. We haven't been doing it rigorously in clinical trials, but both initial and relapse. And then the other question is, how do you determine low and high risk, and does that change your treatment?
So the way we determine low and high risk for the most part, there's two main areas. One is genetics, and we use three big tests, something called the karyotype, something called FISH, and something called gene expression profiling. And it gives us certain numbers and certain information, and we can call people low or high risk based on that. We can also use some of that information to determine what's called the revised international staging system, which makes you high or low risk. But there's another category that's not frequently talked about, and that's biology. And what I mean is that if we give you the standard therapy and you have normal risk cytogenetics and you don't respond as well or you have an early relapse, to us that means you're biologically high risk, and that's a different concept altogether. But It doesn't necessarily change, per se, the drugs we use at the moment. However, it does change some of the concepts that we might use. 3 drugs versus 2, proteasome inhibitor or not, transplant or not, donor transplant or not. So it kind of affects global gestalts or global ideas. We have yet to specifically define individual drugs, though some drugs appear to have better activity in high risk than others.